Hello dear viewers. Today in this video, which is part 4 on nutrition support in critically ill adults, I will be discussing the parental nutrition in critically ill patients. Nutrition support is part of comprehensive management of critically ill patients because it impacts the outcome. I am Dr. Sunil Garg from Essentials of Acute Care. The information which I am going to discuss is up to date as of today, and as a new evidence gather, information may change in future. Parenteral nutrition refers to the provision of calories, protein, electrolyte, vitamins, minerals, trace elements and fluids via parenteral route, means route other than digestive tract, and essentially in the context of nutrition it means intravenous route. The Institute for the Safe Medication Practices has listed parenteral nutrition as a high alert medication in the same category of complexity and potential for error or harm as chemotherapy. Indications of parenteral nutrition is mainly when enteral nutrition is contraindicated. But what are the contraindications of parenteral nutrition? Contraindication to parenteral nutrition support includes patients whose sugars are uncontrolled. Nutrition can be initiated in such patients once blood sugar is under control. Patients with severe electrolyte abnormalities and volume overload or also should not be offered parenteral nutrition. When given for more than a few days, parenteral nutrition must be delivered via a central venous catheter because its high osmotic load is not tolerated by peripheral veins. Parenteral nutrition may be given via a peripheral vein if it is significantly more diluted, means when the osmolarity is less than 900 milliosmol, and this is termed peripheral parenteral nutrition. Central venous access device are the device or the access of choice for the delivery of parenteral nutrition. This includes a peripherally inserted central catheter or PICC or a tunneled or non-tunneled CVC. Choosing appropriate access should be individualized. Short-term administration when parenteral nutrition is planned to be given for less than 30 days. For short-term administration, access via PICC is appropriate. As a less preferable alternative, it may be administered through a non-tunneled CVC at subclavian, internal jugular or femoral site. The femoral site is the least desirable due to an increased risk of catheter-related bloodstream infection. The long-term administration when parenteral nutrition is planned to be given for more than 30 days. For the long-term administration of the parenteral nutrition, PICC is good option because of the relative ease of insertion and removal compared with the tunneled CVC. When possible, use a single lumen catheter dedicated to parenteral nutrition administration, and if a multiple lumen CVC is used, one port should be dedicated solely for the parenteral nutrition administration. Parenteral nutrition is an admixture of solutions containing dextrose, amino acids, electrolytes, vitamins, minerals, and trace elements. Lipid emulsion may be infused separately or added to the mixture. When lipid is infused separately, the parenteral nutrition is termed as 2-in-1, and when lipid is mixed with the other ingredients, it is referred to as total nutrient admixture TNA or 3-in-1. Noteworthy is that the minimum triglyceride concentration in TNA or total nutrient admixture must be 2 or more than 2%, means more than or equivalent to 2 gram per 100 ml, or the emulsion becomes unstable. The exact composition and the infusion rates are tailored to the nutritional and the fluid needs of each patient. With regards to formulation, dextrose 70% is most commonly used. The calorie contribution of dextrose is 3.4 kilocalorie per gram of dextrose. The percentage of the calories that is contributed by dextrose is titrated according to individual factors such as severity of illness, caloric needs of patient, and the underlying condition. It is generally thought that the dextrose should not exceed, or the dextrose dose should not exceed 4 to 7 mg per kg per minute. The amount of dextrose given on the first day of parenteral nutrition should be half of the intended goal. This helps attenuate the potential for refeeding syndrome and hyperglycemia. Dextrose can be increased to goal if electrolytes and glucose levels are satisfactory on the second or subsequent day. Amino acid solution contain most essential and the non-essential amino acids, and the caloric contribution of amino acids is approximately 4 kilocalorie per kg. Lipids are a source of essential fatty acid and calories. The caloric contribution of a typical emulsion is 2 kilocalorie per ml in 20% of the emulsion and 1.1 kilocalorie per ml in 10% of the emulsion. The lipid infusion rate should not exceed 0.11 gram triglyceride per kg per minute. When infused separately from the PN, both 10 and 20% emulsion can be infused via a peripheral vein. With continuing with the formulation, electrolytes are added to parenteral nutrition in amounts required to maintain normal serum levels. Patients with no electrolyte abnormalities are to start parenteral nutrition at half normal salinity, means approximately 75 millicoulant sodium per liter. Sodium is divided approximately 30 to 40% as sodium acetate and the remainder as sodium chloride. For phosphate, sodium phosphate is the preferred source. A starting dose of 20 to 40 millimole per day is reasonable. Potassium may be given as chloride or acetate. Start with 30 to 40 millicoulant potassium per liter. Calcium gluconate and magnesium chloride are usually started at 10 millicoulant per day. Patient receiving parenteral nutrition must receive adequate vitamins and minerals to prevent deficiencies. For most patients, a unit dose of a standard multivitamin and a multi-trace element solution added to the amino acid dextrose lipid admixture is sufficient to meet minimum daily requirement. Do not supplement vitamins and minerals above the recommended daily amount unless a deficiency is documented or strongly suspected. It should be noted that a deficiency is not the same as a low level. Rather, a deficiency occurs only when a lack of a substance causes an undesired health outcome that is reversed or prevented by supplementation. Protein-bound nutrients level drops similar to calcium dropping when albumin level decreases, when their carrier protein level decreases in the setting of inflammation. It is advisable that patients with the cholestasis do not receive copper or manganese as these are excreted in bile. A total bilirubin of 2 mg per deciliter is often used as a cutoff to restrict these. Parenteral nutrition is generally administered as a continuous infusion with a total volume initially administered over 24 hours. The daily volume of parenteral nutrition is tailored to the nutritional and the fluid needs of each patient, while enteral feeding formulas may be concentrated as 2 kilocalorie per ml. It is difficult to concentrate parenteral nutrition more than 1.2 kilocalorie per ml. In general, start the parenteral nutrition at half the daily requirements on day 1, and if tailored without uncontrolled hyperglycemia, precipitous change in electrolyte or reaction to lipid, proceed to the target goal on day 2. The prescription for the parenteral nutrition is written daily since electrolyte needs and the laboratory chemistries may vary daily. In terms of monitoring, the routine monitoring of the patients, those who are on parenteral nutrition, includes measurement of fluid intake and output, serum electrolytes, glucose, magnesium, calcium and phosphate are measured on a daily basis until they are stable, or more frequently if the patient is at high risk of or exhibiting signs of refeeding syndrome. Aminotransferases and bilirubin are measured at least once each week for the first few weeks. Triglyceride level are also measured for the initial 2 to 3 days of parenteral nutrition, and if stable, then weekly for the subsequent few weeks and then monthly. If elevated, more frequent measurements are necessary. Trace elements including iron need to be measured every 3 months. In terms of complication, because central venous access is required to administer parenteral nutrition, patients are at increased risk for acquiring a bacterial or fungal bloodstream infections. It is associated with several metabolic complications including hyperglycemia, serum electrolyte alterations, macro or micronutrient excess or deficiency, refeeding syndrome, and Wernicke encephalopathy and hepatic dysfunction. Hyperglycemia is managed using the similar principle to those in all critically ill patients. Hypertriglyceridemia or worsening of existing hypertriglyceridemia may result from the infusion of lipids. Concentration up to 400 mg per deciliter are acceptable during therapy without altering the amount of lipids in parenteral nutrition. But triglyceride level more than 1000 mg per deciliter are a contraindication to lipid infusion. Certain precautions should be taken when prescribing lipids. Patient may have allergies to some of the component. Hyperlipidemia may be exacerbated and some emulsion may be more unstable. Refeeding syndrome is a potentially fatal complication or the condition, and Wernicke encephalopathy is more challenging to diagnose in critically ill patients. Both conditions are more common in patients with anorexia and alcohol use disorder. Rarely, patients who have long-term fat malabsorption or are chronically dependent on parenteral nutrition develop carnitine deficiency. Now coming to peripheral parenteral nutrition. Peripheral parenteral nutrition can be delivered for short periods through a peripheral intravenous catheter, means for only few days. Peripheral parenteral nutrition is useful when central access is delayed, and it is also used when central access needs to be temporarily removed and continued feeding is critical, for example, during the line holiday for the treatment of bloodstream infection in a malnourished patient. Calculation for the peripheral parenteral nutrition are the same as for the central parenteral nutrition, with the exception that fat usually composes 50 to 60% of the calories in peripheral parenteral nutrition. This helps minimize the volume while keeping osmolality low. Osmolality of the peripheral parenteral nutrition must not exceed 900 milliosmol per liter. Here I finish. If you have any feedback, suggestions or comments, please write down them in the comment section box. Till then, bye and take care.